Okay, thanks everyone for joining us today for the Bridging the Gap, Delivering Equitable Health Services with People with Disabilities training. I'm joined today by several presenters, Mackenzie Jones, Isaac Baldry, Meg Ann Tracy, Jed Barton, and Aaron Blay. And I will put in the chat the document that has some more information about each of the presenters. But I want to give them the full time here to share with us all the great information and training that they have for us. So I'm going to kick it off to you, I believe, Mackenzie. Thank you so much.
Thank you, Anna, for having us. And today we don't have Jed with us. He'll join us for the December 3rd, part two of the webinar. So hopefully that encourages you to sign up and attend that part of the webinar. My name is Mackenzie, she, her. I'm a white woman with short blonde hair and glasses, and excited to be here. Let me start sharing my screen and we can get going. Here we go. So we are today doing part one of a webinar series called Bridging the Gap, Delivering Equitable Health Services with People with Disabilities. And we are a mix from the Montana Disability and Health Program, me, Aaron, and Meg, and Isaac Baldry is joining us from the University of Montana Rural Institute on Inclusive Communities, where that is also where Meg is from. So to get our juices flowing, we're going to start with a video, and Aaron is going to facilitate a couple questions after the video. So watch, learn, enjoy.
For those of us who don't live with a disability, it's easy to go through our day-to-day life without thinking about a lot of these physical barriers. They might be actually at the policy level. Just because someone's living with a disability doesn't mean that they should have limited access to every other part of their life, which is absolutely the opposite of what our mission is. Our mission is to ensure the health and safety of all people in Lewis and Clark County. And we can't do that if we are accidentally, inadvertently leaving people out.
So within the department, we started by just bringing together the work group. And so that was something that we didn't have before. So that was kind of a new and innovative way of approaching a need within the department. We found a lot of success inviting individuals with disabilities into that work group to help us learn and gain a greater awareness and a better perspective.
One of the great things that's come out of the inclusiveness work group is our inclusive policy at the local public health department level. That policy is really pretty groundbreaking. So when we make a decision to implement a policy, every decision that's made after that will be made through that lens.
Anybody can look at the Americans with Disabilities Act, talk about path of travel and how high a countertop should be, and I was invited to the table to fill a specific role. And that role was to give the perspective of somebody with a disability, not just how my physical disability affects, but also the mental and emotional part that everyone that struggles with a disability faces. So little things like the door into the bathroom. And so by just making a small adjustment in the tensioner at the top of the door and make it easier to open and close, improve somebody's life right there, making sure that signs are identifiable and they mean what the person who placed them meant for them to say. There's a system now that can let the fire department know I'm here, I'm safe in this area, but I am going to need assistance getting up and out.
When we create a culture of inclusion within our health department that bleeds into our community, we start to change the way that we think. Our lens shifts. Some of the big outcomes of the project are the inclusive wayfinding system that the city adopted was made inclusive by choosing specific fonts and colors and sizing to make sure that it's visible and readable to everyone. Charging stations that are located in the city-county building and the Capitol building are great examples of small changes that can happen that make a big difference.
We did a community-wide assessment that showed that we have this really great trail system. However, the trail system didn't necessarily meet the needs of individuals with disabilities. So we used walk audit that allowed us to see through their eyes and through their perspectives where our community fell short and where we did really well, and we could make some plans and adjustments from there.
The reality is that a city can be held liable if someone doesn't have access. There have been lawsuits that have been filed and won by individuals in communities, and as a result, a city or a municipality is responsible for, over time, making those changes. And we use these walk audit trainings to do ongoing work in the community to make sure that as changes are made to our built environment, they are done in an inclusive way. You don't have to wait for funding. There are so many small changes that can be made that don't actually cost any money. Bringing people together, asking the experts, asking people with lived experience, those who do live with disabilities every day, and bringing them to the table. That's been the greatest eye-opener for our work group and for me individually. So it's really exciting to see that long-term, when you create a culture of inclusiveness, it's not a heavy lift anymore for us. It's just happening naturally, and it's the way that people do business, and it's the way that people see the world.
Thank you, Mackenzie, for sharing. And we just want to hear from all of you. So feel free to come off of mute or share in the chat. But what did you see or hear that stood out to you while watching that video? Or maybe there was something that was most important to you while watching the video, or maybe what was most relevant to your role. Great, I see in the chat, so small changes can make big differences in a life. Thank you. Yeah, and again, feel free to come off of mute or share in the chat. We just wanted to get a few perspectives from watching the video and what we thought. I really appreciate the curiosity of those in the health department on how to do it better. It is so important to get folks who live outside of the disability community to be curious and engaged in the work. Thank you. Anyone else want to share? Okay, thank you. Mackenzie, I'll turn it back over to you. Thank you for participating with the comments in the chat. We appreciate it.
Thanks, Erin. So I realized I just dove in, gave no context of the video at all. And so in a couple slides, you'll get to know a little bit more about our team, what the Montana Disability and Health Program is, and who we are. This video came from a project called the Inclusiveness. Wow, it left me. Inclusive Communities Project through the National Association of Chronic Disease Directors. And if you were able to see Meg Tracy's video here with us today, she was in the video multiple times. She was the expert consultant on this project. Montana received funding. We were one of 5 states to receive funding for two projects. This one in Helena, Montana, and then the other one was in Butte. And at the end of our slides, which we'll send out at the end of this presentation, has the video to the Butte project as well, which is the development of an inclusive park, Stodden Park in Butte, if you've ever been. And an inclusive park is not just an ADA accessible park, but truly meets the needs of any person of all abilities, of all ages. Um, Meg, is there anything you want to add about that project?
Yeah, and this is Meg Tracy. Sorry, my internet just went down. And I think for us in Montana, it was a really quick opportunity that we had to organize with local health departments for a grant from the National Association of Chronic Disease Directors. So um, they all Butte, Silverbow, and Lewis and Clark both had projects where they were, I really appreciated the comment about curiosity, where they were open to integrating disability into funded projects. It had not been a perspective that they thought about. And there was just a little bit of funding from NACDD to start working to better include people with disabilities in a wayfinding project and into the planning of a 20-year transportation plan in Butte. So, yeah, I really appreciated that curiosity. Sometimes it's just a little bit of resources to create the staff training and form those new relationships. So I just wanted to call forward that it's curiosity, it's willingness, it's big funded projects, and then just sometimes a little bit of funding to start to build in the disability perspective into the project and make it better for all.
Thank you, Meg. So in the video, you saw what they mentioned to be an inclusive interdisciplinary walk move audit where people came together in colorful vests and walked through a space to determine if it was accessible or not, or if there were ways to make it more welcoming to cyclists and people who use strollers and all types of folks that want to use active transportation. On December 3rd, we will go into depth on what that process looks like because that is the policy systems and environmental change assessment process and the community gathering of how we make these changes. Today, we're focusing on the why, some of those barriers that exist both in a healthcare setting as well as in the community. Isaac Baldry here is going to provide insight on his personal experience in a healthcare setting, both with a primary care physician as well as what happens if an emergency happens when he's in a different location. What is it like to visit an emergency room? So we are going to move forward and provide that story from what we do and why we do it all the way to how you can make change in your communities. So we are one of 10 states that are funded with the Disability and Health Program, and we are funded through the Centers for Disease Control. The 10 states on here is a map of the United States, and these 10 states are highlighted: Oregon, Montana, Utah, Missouri, Georgia, Ohio, Michigan, New York, New Hampshire, and Massachusetts. And so we all are funded to do similar projects as well as tailored projects for our states. Um, and within the idea of disability and health, we approach disability as a community. Sometimes we hear disability, disease, and death together and decreasing those outcomes. And we're thinking about disability as a community that experiences health disparities and how we can work together with that community to improve the environment, improve access to transportation, access to housing, access to healthcare, and so much more. Recognizing that disability is just like another demographic group of whether it's race or gender or sexual orientation. And so working with that community to identify barriers and inclusive solutions together. And we, as the Montana Disability and Health Program, we aim to increase health and wellness opportunities with and for people with disability. And I like to emphasize the with because we cannot do it without the community participating in our projects, participating in our presentations, participating in our advisory board. Um, nothing without us, nothing about us without us is a phrase might have heard before. And one of our dear colleagues, Karen Korb, also says nothing without us. So making sure that the disability is included in everything that you're doing across the healthcare, allied health systems, and really anything, because depending on what survey you're looking at, between 18 and 29% of Montana adults have disabilities. So if you are ignoring support needs or including people with disability, you are ignoring 1/3 of our population. So we do this by gathering data, understanding the barriers that exist, um, through education, like trainings like this, webinars, um, sharing tools and resources that people can use in their communities in order to support um, themselves or families as self-advocates or health providers and other public health professionals, including people with disabilities. We cannot do this work without our community partners. We'll talk about the Centers for Independent Living a little bit later. There are 4 in Montana. But also, as you can tell, we're already communicating with the University of Montana, the Rural Institute. There are so many partners, over 100 across Montana that we work with throughout the year. And then together, we are able to make policy systems and environmental change that support this improved health. So some of the existing barriers, like I said, 29% of Montanan adults have a disability or identify as having a disability. Some existing barriers to improved health. Over here, I have um, a model of the social determinants of health. It's an image showing employment, health or education, healthcare access, access to housing, living in the community, living in the place you want to live, working, playing, worshiping in the places you want to be, and as well as employment access. So public health looks beyond just thinking about decreasing in chronic disease or chronic disease prevention and management. We are now looking at a larger scale, as many of you most likely know, at the social determinants of health, the things that impact our health long term. And more Montanan adults with disability than adults without disability need supports in order to access chronic disease prevention and management opportunities. Housing and transportation, going to school or work, living in the community, and accessing health care. And to emphasize, let me go back. So the work that we do tries to decrease the barriers toward accessing these opportunities in the community, and recognizing that we all have to work together to get there, and recognizing that there's a lot of education and work that we need to do together. So another article that I've shown over the years is by Lisa Iazzoni and her team, recognizing that physicians report bias toward patients with disability. And this is not the only group of people that report bias, but this is a significant article in this field. For example, most or 82% of physicians that took the survey perceived worse quality of life for people with disability. Only half, or 56%, strongly agreed they would welcome patients with disability into their practices. Less than half, about 41%, were very confident in providing the same quality care to people with and without disability. And over on the left, I have a photo of a provider and a patient with disability. However, she doesn't just say these are the barriers, and I think that's how we approach it too. We can't just like, here are the barriers that exist. We come in and we work with our disability advocates and our partners to understand what solutions are available and what can we do to improve our communities. And she found, Lisa Iazzoni and her team found that increased confidence in providing quality care was associated with increased likeliness to welcome disabled patients into your practice. So if you felt more confident that you could provide that quality care, then you're more likely to include patients with disabilities in your practice. And so what does that mean? That 80% of physicians strongly agreed that understanding their patients with disability is very valuable. So if we can do trainings like this, if you can connect with your community partners and disability organizations in your community and build that confidence, then you are going to be a better healthcare provider, allied healthcare provider to folks with disabilities. And this is a photo of Lisa Iazzoni. Okay, so getting a very brief overview of what types of barriers exist, I wanted to give us plenty of time to talk with Isaac Baldry about his specific experiences as a disability advocate, as a uh, national presenter. He has so much experience in the transition and healthcare world. And if you haven't heard that word before, it's the idea of youth with disabilities transitioning into adulthood and finding, and people without disabilities also transition. You go from a pediatric provider to an adult provider, or you go from going to school to either going to college or getting a job. So we're all processing that transition, and it just may look different for people with disabilities. And Isaac is an expert within Montana that educates people across the nation about this topic. So Isaac, you ready to jump in? Okay, I'm going to stop sharing for a minute while we do our presentation. That work? Great. So I'll start with my first question. Isaac, is that where we're going? Okay. Tell me about your healthcare experience as a kid and your transition to adulthood.
My name is Isaac Baldry. I have lived in rural Montana all my life, same little town. I moved there before I was 1 and had the same doctor until March of 2022. Dr. Young was the pediatrician who first recognized that things were different for me. The first person to say cerebral palsy. It was not that just I went to him as my doctor, all my siblings saw him. In fact, all the kids I knew saw Dr. Young. As I got older, Dr. Young made sure I was a part of the conversation and planning for my medical care. When I was becoming an adult, I took him an advocacy forum for how I would be the decision maker for my health care. We talked it over and knew how we would work together. We also talked about my moving to an adult doctor, but he was fine if I just stayed with him. I liked that idea. Why move when you have someone you trust and you know you can talk to? In learning to be a decision maker, as a young adult, I went to trainings to learn about tools and options and what others were using. I started to look at how I wanted to be supported in all the areas of adult life. It was in these trainings I learned about healthcare transitions. I think your health is a foundation. You have to be healthy to do everything else you want in daily life. I went back and looked, and I have been training and talking on healthcare transition for at least the last 10 years.
Thanks, Isaac. So you have obviously a very strong voice and have learned how to use it with augmentative and alternative communication. Tell me a little bit about how you learned to use your voice.
Because communication is one of my barriers, As I was thinking about what tools I would use, I also had to think about how would I communicate the information I wanted others to know. How would I get them to realize my abilities and not just make assumptions because of the wheelchair or my difficulty with spoken language? I learned about training opportunities specific to people who use augmentative and alternative communication. I joined every one I could find. I adjusted my thinking and my tools to better match who I was and how I wanted to communicate in different environments. And being honest, I hit the panic button when people come up to me and ask me questions, and I am not prepared. My immediate response looks something like a deer in the headlights. Wide eyes, and I don't want to move. Because I know I do this, I try to be as prepared as I can. It is what I need, so I can be a partner.
Thanks, Isaac. So earlier you mentioned discussing your transition from pediatrician to an adult doctor. When you turned 18, you didn't need to transition, but now you have made that transition. Tell me more about what this transition looks like for yourself and others with disability.
Often, people don't know, as someone is turning 18 and becoming an adult, they will need to move from pediatric care to an adult healthcare provider. It can feel like one more thing you have to do in transition, and there are already a lot. If we don't help young people connect to a new doctor, they might not do it. They might just wait and wing it, unless they get really sick. And then they have to go to the emergency room for care. They don't have anyone working with them to stay healthy. When I needed a new doctor, because my doctor retired, nobody wanted to really be my doctor. One of the nurses, who had been a part of my care team, had to be the one to say, "It will not be that bad, he does not need much, and someone needs to do this." They met as a group and decided who it would be. I was nervous, as I was starting with nobody really sure they could be my doctor. It was also a time I really needed a doctor. My wheelchair was broken and needed parts. You can't get parts without a prescription. I went to that first visit, super prepared. I brought all my paperwork for how I make decisions and had built a new folder in my app on my iPad just for communication in the doctor's office. She was great. Dr. Gallo listened, asked questions about my past healthcare, my current concerns, and made sure I felt comfortable that she was now a part of my team. Because I told her I like to do things online, she made sure, after our visit, that I was with someone from their team, in front of a computer screen, to learn how to access their online portal. She walked me around the desk where no one is supposed to go. She knew I needed to see and follow how to use the computer site. Everyone has been really good when I go to see my primary care doctor. It starts outside. I have parking. The door has an opener. There were wheelchairs inside the first door, and I could not access the button to the second door. When I told them the problem, they fixed it. Staff at the clinic I go to hold doors for me to drive through and make sure things already in the patient room are moved to create space for my wheelchair.
Thanks, Isaac. I'm glad your transition to Dr. Gallo went well. You've talked about working with health providers who you know or have the time to get to know. But what happens if you need emergency care?
Fortunately, I do not have to go to emergency care often. If it does happen, it is probably one of two things. I might be traveling and not at home, but whatever is going on needs medical care now, and can't wait until I get home. Usually, this means it is problem number 2. I cannot get the muscle spasms I sometimes have under control, and I am in a lot of pain. I carry medicine with me, but sometimes the spasms are too much, or maybe all my body, and I could not swallow my pill. For me, when I go to the emergency room, pain is way high. My muscles are tight, and I am just trying to be able to breathe. Registration is difficult, but I get it has to be done. I will probably need assistance communicating. I will not want to answer questions like name, age, date of birth. Someone else will have to give this information. I do have that information in my ACE, in case of emergency, app on my phone. Focusing to point on my device is not going to work well. I try to plan ahead. I carry a copy of my advocacy forms on my phone. My advocacy form, my medical power of attorney, and a HIPAA release. I can show these to people or email them to print. These are also in my electronic medical file, but that may not be available. Hopefully, someone is with me that knows where my info is or can give the information.
Thank you, Isaac. So even with the forms on your ICE or in case of emergency app, providers still need to get answers from you about how you're feeling in the moment. What are ways a health provider can easily communicate with you?
Hopefully, the person with me can help me with a simple form of communication we have practiced. What I can do is answer yes or no. I think it is helpful for medical staff to ask if yes or no questions will work. It lets me know you are listening to me and need my input. To make it simple, I need targets for yes or no. For me, 2 hands closed in a fist extended toward me works. The person showing me their hands needs to tell me which is yes and which is no. Hospital staff can ask me questions this way. For some people, fists could be scary, so word cards with yes and no and visuals to match could be used for the targets to touch. I also need a way to communicate my pain level. We again go to what can be right in front of me. Using someone else's hands again, open toward me, I can choose what number my pain is. I need to know which is low and which is high. We call it 1 to 10. Another support can be if I have a drawn figure of a person or a small model, I can point to where it hurts. Because of my cerebral palsy, if one set of muscles are spasming, others might start too. With my whole body responding to something wrong, sometimes it is hard to say where the pain or problem is. Everything is firing at the same time. I need to be able to say, I am unsure. I have used these ways to communicate to people when I am coming out of surgery. I let them know this is what works for me, and then we can use it as I am waking up.
So Isaac created a video to describe what he was talking about in his presentation, so I'm going to play that for communicating pain level.
Hi, Isaac. I came to check in on you about the pain you were having. Can we use that 10-point scale? So if this is really low, very little pain, and this is really high, a lot of pain, where are you at about now? A 6? We gave you some medicine to see if it would help. If this is yes and this is no, is the medicine helping you? Yes. One last question before I go. Would you like something to drink? Yes or no? No thanks? I'll see you in a little bit. Hi,
Also, Isaac has shared with me that if you have a handy tool like this pain scale from 0 to 10 with smiley faces and the descriptor words underneath, that is also a way to a visual for him to point to. And now I'm going to go back to Isaac.
The last piece I want to share about emergency care is waiting is hard. Things feel like they take a long time. Sitting in the waiting room to go back for care is hard. Medical staff touching base with me, letting me know what is going on, helps me remember people are working on it.
Thanks, Isaac. Now, thinking beyond what supports you already have in a healthcare setting, what would be your ideal healthcare visit? Walk us through what full inclusion and accessibility look like for you.
In my ideal world, for medical settings, something would pop up on the office computer screen to tell medical staff I use a motorized wheelchair and a communication device. The on-screen note will also tell them I will have a support person with me, but that I am the decision maker in my healthcare. People providing me care would know this and expect it. In planning for my visit, staff would have considered the route we would take. It would be accessible to my chair. They would wait to ask me questions until I was not driving. I need the same hand to drive and talk. Where we are going would be ready and accessible for the wheelchair. People would smile when they saw me, instead of looking scared or shaking their head looking down. People would accept all the ways I communicate. I might point, use modified sign, shake my head, say yes, or use my communication device. All are equal ways for me to interact with them. In the ideal, when I needed a procedure or medical test, we would talk through what needs to be done ahead of time. We would work out the kinks and have a plan before the day of the appointment. I would even be more relaxed because I knew there was a plan and people expected me.
Thanks, Isaac. So I believe that your ideal world is possible if we all work together. And that leads us into talking about accessible planning for healthcare facilities. And it could also mean public health um, clinics as well. So we need to understand the barriers you and others with disability experience in healthcare settings in order to find those solutions. Tell us what accessibility planning means to you.
With a chance to talk on accessible planning for healthcare facilities, I cannot resist talking about my real experiences in medical care appointments. This is how it goes. I need to set an appointment for some kind of medical testing that my doctor wanted. If it was an option, I did this online. If not, I would have to call to make the appointment. Because I use a communication device to speak, the person answering the phone might hang up before I even got to why I called. I now have programmed and say, right after hello, please don't hang up. I have difficulty speaking, so I use this computer to speak for me. Hopefully, this worked and I get my appointment scheduled. On arrival, Parking is the first challenge I encounter. Probably, I will need to be dropped off, and my support person will have to come back after they find a place to park my accessible van. I will go to the check-in counter. I have a folder on my communication device, just for medical registration. I try to have all the information ready. Next, I am called to go for care. Two things can happen now. Either the person who comes to get me hits the panic button as soon as they see me in a wheelchair, or they tell me I cannot have my support person come with me any further. I have to remind myself to take a breath and find out what support the person in front of me needs. What barrier will we tackle first? Easiest first. If it is my support person, I tell medical staff, no, I am bringing this person with me as my support for communication, and we move forward. If it is the wheelchair, I start with what is it that they need me to be able to do that they do not think is possible. I cannot tell you how many times I have been told, oh no, we didn't realize you were in a chair, we cannot see you, you will have to go somewhere else for your care. If they will give me a chance to talk through things with them, what they need, and what I think would work, we can usually find a solution. It may not be ideal. I may not have the privacy I would want, or I have to be lifted or moved by my support person. I have to understand what they need, and they have to understand what might work, even if it is different. Everyone will have to compromise. We should have the same goal of how can we get the testing information done.
Thanks, Isaac. So it sounds like listening and patience seems like a really important skill on both sides in these moments. Yeah. So to close us out, what is your call to action to the participants on this call today?
When I think about a call to action, I start with, have you had a person with lived experience walk through, look at, and discuss the spaces where you see patients? Do you have doctors who expect to care for people with disabilities? 1 in 4 people now have a disability. We need adult care providers who know things will be different, but feel ready to provide care. Next, plan through how people with disabilities will access all the places within your building. What tests or equipment will be needed? Is it accessible and private for all? Does everyone get the same care experience? Last would be to have on-hand tools, plans, for ways to communicate with people who need support. What are the different needs? What do you have that can be accessed quickly for communication? Together we could be better prepared for success. Thank you for listening.
Thank you so much, Isaac. So after hearing all that Isaac shared about his experience, what his dream inclusive situation is in a healthcare setting or public health clinic, I want to have our team briefly talk about what can you do. And as a reminder, on December 3rd is part 2 to dive deeper into what we talked a little bit earlier about having people with disabilities walk through a space together. And as Isaac said, that is one thing you can do. Other things that you can do is identify quality resources. One of them is the Screening for All from MCD Global Health. I was a part of the advisory board for the development of these tools with one of our Montana disability advisors, and people provided immense input on their personal experience as people with disabilities. And so these resources are made by, for, with people with disabilities. About preventative screenings, there are resources for patients as well as healthcare professionals. And I'm going to pass it over to Erin to give you a few more resources.
Thanks, Mackenzie. So this is the responsive practice training, and these are 2 modules that will help you enhance your ability to deliver disability competent healthcare. So that on the screen, it says Module 1, so providing healthcare and screenings to individuals with disabilities. And then Module 2 goes into that accessible and adaptive communication, some of what Isaac shared during his presentation, but just dives a little bit further into it. And it's actually 2 modules that are using real people and kind of walking through the appointment and how that looks, and how to provide the best possible care and scenario as well for their appointments. So they take about an hour and a half. They're self-paced, but you can either scan the QR code or we'll pass along the resources. In Montana, there are CE credits available for physicians, pharmacists, and nurses. And then in Montana, one of our partners that we work with are the Centers for Independent Living. On the map are shaded areas, and we have 4 Centers for Independent Living here in Montana. So the yellow shaded area is the North Central Independent Living Services. In the blue is Living Independently for Today and Tomorrow. Their acronym is LIFT. And then in the salmon or orange colored is Summit Independent Living Services. And then up in the upper left is the pink or the magenta color, and that is oh, sorry, I did that backwards. The pink magenta is Summit Independent Living, and then the salmon colored is Ability Montana. And then within those areas are the green shaded reservation locations that are also covered and supported by those Centers for Independent Living. And the Centers for Independent Living make community living possible. So they are disability led. Over 50% of their employees have disabilities, and they're consumer driven. So they are helping people live independently in their communities. So allowing them to participate in different things. And just participate in their communities. So whether transitioning from one age to the next age, or transitioning that care, or transitioning between housing. They provide advocacy and support at all levels. So again, talking about different services that might make their community living possible, whether it is occupation services, housing, transportation issues, are just a few examples of the support they provide. They're a great resource hub to connect people to those services and supporting them to live, work, and play where they want. Our Centers for Independent Living also host Living Well in the Community workshops. So feel free to reach out. We'll provide their information and contact information as well. But these are workshops that are grounded in independent living philosophy that can help people with disabilities set those quality of life goals, practice problem solving and managing emotions, and then learn tools and skills to help achieve their goals, and helping them practice that self and systems advocacy.
And I'm going to pass it over to Meg to describe another thing that you can do in the work that you're doing.
Great. Yeah, thanks. I'll just add on for folks who are new to Centers for Independent Living, and think of them as the network of community-based organizations that support people to live in the community. People who are at risk for being institutionalized because they live in a narrower margin of health. So that might be older people, and that network of partners is usually the area agencies on aging. Um, and um, and then Isaac and I work for the Rural Institute, and that's one of the sister programs funded through the Intellectual and Developmental Disabilities Act to support community living. We also have Disability Rights Montana, as well as our Developmental Disabilities Council. So it's a big network that's really working to support people who have either aged into disability or have lifelong disability to be living in the community. So just wanting to further connect you. If you're working with your area agencies on aging, it's just an extension to bring in some of these other partners to represent people with disability and take a disability-led approach in your work. And with that said, I will introduce some of the disability demographic questions. These questions are core to shifting from treating disability as something to be prevented and something negative to recognizing that it's a large part of our community and a huge part of people's identity. And there's a lot of strengths that you can bring into your programs, into your systems, into your approach when you recognize disability as a positive part of the human experience. It's natural. All the things that Isaac shared are from the disability perspective. So these questions are core if we're only looking at disability as a condition or something that we can bill for. We continue to take the medical model of disability, which is something that we have tried to really shift to a social model. Here we're saying just like, are you of a certain age? When were you born? This is asking, do you have a disability? And these questions have been something we've worked on as a community for many years. In the census, 6 questions, what we call the ACS 6, were adopted in about, I want to say 2015. Maybe I'll get my math right on this, but it was around the Affordable Care Act time. And in the Affordable Care Act, there was actually language to use these questions or a core set of questions in all public health surveys. So there was a work group that identified a minimum standard question set, and these are the ACS 6. There's also the Washington group set that has traditionally taken more of a medical model in defining disability. These come from the census and are part of their demographic set. So they tend to be similar questions if you see the Washington group, but we really think that if you add these kinds of questions into your surveys, if you're looking at patient satisfaction, or you are doing your community health improvement plan, it's really important to think about your population and making sure you're hearing from people with disability. So adding these disability demographic questions, are you deaf or do you have serious problems hearing? Are you blind or do you have serious difficulty seeing even when wearing glasses? Do you have serious difficulty climbing stairs? And then there's a question about because of a physical, mental, or emotional problem, do you have serious difficulty with decision making? And we'll put in the specific questions, but the other two are about whether or not you need supports for going out into the community, grocery shopping, seeing a doctor. Those are what we call independent living supports. And then we also have supports for activities of daily living, or here we're calling it self-care disability. So there's 6 questions, and they really help you to disaggregate your data and better understand whether or not your programs are reaching people with disabilities, how they feel about your programs, what they have to say about your planning for your community health. So with that, I think I'm going to turn it over to Mackenzie.
Sure. Thank you, Meg, for describing those questions very well. And another way to use the question response is to use those questions to get information about people's support needs. So if you are in a healthcare setting or you're working in a public health clinic and you better want to understand not only do they have a disability, but what does that mean? What support needs does this person need if they identify as having a disability? So with that, you can better understand communication and environmental barriers, as Isaac was describing, as well as coming up with an inclusion plan for each patient. And then if you are in a healthcare setting, you can update that problem list, but really it's every time you meet with someone, you want to just follow up to make sure those support needs are being met because they might change from one day or to another. And then conducting long-term planning with the disability community. As Isaac said, don't just stop with the one patient. Recognize that in the future there are going to be more patients. And if you build it, people will come, they'll feel welcomed, they'll feel included. So, and this is one of our friends and disability advisors, Lizanne Caderna, in her own Pilates studio, recognizing that she advocates daily about what her support needs are. As a reminder, join us for part 2 on December 3rd to learn even more about our inclusive interdisciplinary walk move audit. We'll discuss short-term and long-term policy and environmental planning. And we'll get to talk with Jed Barton, who works at a Center for Independent Living, about his experience leading those I2 audits. We'll send this PowerPoint out later with additional resources. And if you want more, please email us. Our contact information is at the end. We'll send this link out too. This is our evaluation for letting us know how we did, what you learned from this training, this webinar. And our contact information, that'll get sent out later. If you need it right now, we can put it in the chat. And we have a few minutes for questions. And I did see a couple questions in the chat. Deanna, if you wanted to come off mute and if a question didn't get answered, we're happy to answer it. And if anyone has a direct question for Isaac, you can either say it in a yes/no format, or you can email him directly and he'll provide a full response later.
Mackenzie, it's Meg. I just want to share a little bit about the prompt to how do we organize to make these kinds of systems changes that Isaac was really pulling forward. And I will just mention a key policy is your procurement policies. So the Veterans Administration adopted in their procurement policies what we call the ADA Access Board. Through ACA, they were charged with developing accessibility standards for diagnostic equipment for healthcare organizations. And so the VA, as an example, adopted those standards into their procurement policy. So as I think this really awesome chat informs, like anytime that they get rid of an old piece of equipment, they look to the diagnostic standards to buy a piece of equipment that is accessible. And I will look and see if those diagnostic standards from the access board are still where they used to be. It might take us a minute and we would certainly share those out.
If you have a question, please raise your hand. For accessibility, I'm going to read out some of the questions and answers in the chat with the time we have. Deanna wrote, how can we make movement within the Academy of Medical Educators so that they push to curricula around this population? We are otherwise relying on people stumbling on these kinds of trainings to get better at providing care. Meg said, great question. I recently co-authored this article with medical students and colleagues at Jefferson Health. It reviews current efforts in medical education to shift how disability is taught. Importantly, the student perspective took it beyond understanding disability to the role of medical providers in affirming disability as a core part of who patients are and their identity. And then she provided in the chat the article. Thanks, Meg, for doing that. And then the question that Meg was responding to just previously was, is there a way for us to advocate for making all equipment accessible for all populations? I'm thinking about scales in clinics and hospitals that are not wheelchair accessible. This feels like an easy thing to fix so that as scales break down or stop working, they can just be replaced by accessible scales. Same goes for examination tables as they are being replaced. They could be switched out with high-low tables that adjust to the height needed for people to safely or independently transfer. This feels doable, but not sure how we can encourage or mandate these changes. That would make such a difference in care. Great questions.
And this is Meg. I'll just add Isaac's recommendations are spot on. I think we can work where and speaking about making small changes, asking local people with disabilities, your Center for Independent Living, your patients with disabilities to come and just walk through the space with you on a regular basis and put that feedback right into your capital improvement plans or into your quality improvement plans. So that it isn't just like a conversation and we did our due diligence. It really is going into your planning to make your facility better. And we did a statewide project using our accessibility ambassadors, and we'll talk about that. But it really placed action items into HRSA grants for capital improvements, and three of our community health centers all rebuilt for better accessibility based on what they found through an accessibility ambassador project. So I just really want to call forward just some of those really easy things to do, plain language kind of recommendations from Isaac. They're really important to put into your next staff meeting.
Thank you, Isaac. Thank you, Meg and Aaron. I'll pass it back to Anna to officially close this out.
Well, thank you so much, everyone, for joining us today. Special thank you to Mackenzie, Meg, Aaron, and Isaac. Thank you so much for the information you provided, the great discussion, and we look forward to part 2 on December 3rd. If you return back to the portal, there is a short evaluation for achieving your certificate for attendance, should you need that for your own records, and then we'll follow up with all of the attendees with the resources and the slide deck provided today. And again, if you have questions, you can find us at contact information that will follow up from this meeting. So thank you all so much. Thank you. Have a great rest of the day and happy holidays until we see you again.
Thank you.
Take care all.